Hello, my name is Dr. Joseph Kamelgard, Director of the Obesity Treatment Center here at the University Hospital, part of New Jersey Medical School and the University of Medicine and Dentistry of New Jersey. If you're watching this videotape today, that means either you or a loved one is considering the surgical option for treatment of morbid obesity. What I'd like to do is talk with you over the next hour or so about some of the things that need to be considered when an individual is thinking of the surgical option for morbid obesity. I'm going to talk about the philosophy of what has gone into developing this program here at the University Hospital. I'll give you some insight as to my background and my position as Director of the Obesity Treatment Center. We'll talk about the various options that are available with regard to the different surgeries, and we'll talk about risks and complications, and ultimately go into goals and expectations. Following viewing of this videotape, you're going to meet with me personally, one-on-one. We'll sit for 10 minutes or so, and we'll talk about some of the specifics, how this relates to you in your particular situation. So with that in mind, I'd like to get started. My background in training is in general surgery. I performed my training in Philadelphia at Medical College of Pennsylvania and Hahnemann University Hospitals. After I finished my surgical training, I went for additional training in advanced laparoscopic surgery or minimally invasive surgery. That extra year of training was performed at Baylor College of Medicine in Houston, Texas, and it was directly as a result of that extra year of training that I was recruited to this institution, the New Jersey Medical School and the University Hospital, where I head the division of laparoscopic surgery for the Department of Surgery. Once I was here, I was approached by the surgeon who'd been doing the obesity surgeries and asked if, with my background, if I thought that I could perform these surgeries using the laparoscopic techniques. Now, I wasn't very familiar with them, with the surgeries for obesity, having not been exposed to it. So I decided I would start to become familiar before I gave an answer. I began watching the surgeon performing his open surgeries for obesity. I went to the national meetings, took the courses, did all the fact-finding, and then came back and gave him my report. Basically what I told him was that people were starting to talk about it. This was before the summer of 1999 when Carney Wilson had her surgery. So this wasn't as popular at that point, but the guidelines being developed, which are still the guidelines for today, are that it's not enough just to have background experience in advanced laparoscopic surgery. One also needs background and experience in surgery for obesity prior to performing these operations. With that report, I was invited to begin to participate with the obesity program. So I started out going to one of our affiliate hospitals, working with the surgeons there, learning their techniques in open surgery for obesity, open bariatric surgery. After that, I came back here to the University Hospital to work with our surgeon to learn his techniques in open surgery for obesity. After about a year's time, the surgeon here came to me again one day and said he wanted to retire, and he asked that I take over the whole program. Now that was a huge compliment and a huge responsibility, so at first I wasn't sure if that's what I wanted to do. After speaking with the Chief of Surgery, Chairman of the Department of Surgery, it was decided that this was probably a very good thing and that I was more than capable and qualified for the task. So we did several things. The first thing we did was we launched our website. The second thing we did is we went out on an aggressive public awareness campaign, public speaking several times a year at numerous locations. We instituted protocols so that we could standardize the care that our patients received preoperatively, during the hospitalization, and then during the follow-up period. The last big opportunity, so to speak, for me personally came when we were able to put together a team, fly out to the West Coast and spend a week's time with the two surgeons who pioneered this operation with the laparoscope, Drs. Whitgrove and Clark. We used their equipment, they trained us one-on-one, and eventually we came back from California, purchased the same equipment that they're using in California, installed everything, trained the staff, and since January of 2001, we've been offering the laparoscopic option to patients who are candidates. Now, not everybody's a candidate for the laparoscopic option. Candidacy for the laparoscopic option is determined by several factors. The insurance company has to be willing to pay for the operation with the laparoscope. It costs more. The patient has to have had no prior upper abdominal surgery performed using open surgical techniques. The person has to want the laparoscopic option. And we have limitations on the size that a patient can be. If a patient's body mass index is over about 50, which is about 300 pounds for most patients, the technique of using the laparoscope becomes extremely difficult, and with the increased difficulty, it becomes less precise, and the risk of the surgery goes up dramatically. And since we have the option of performing the surgery the open way as well, in those instances, we no longer offer the laparoscopic option. That doesn't apply to everybody, but again, if a person is a candidate for the laparoscopic option, they can then choose between the open surgery or the laparoscopic surgery. A little later on, I'll draw some pictures. I'll try to explain some of the differences so that you can begin to think about which of the two options, if you're a candidate, you might be interested in. What I'd like to talk about next are some of the concepts or philosophies that have gone into the making of this program. The first and foremost concept is that surgery is high risk, and safety can never be guaranteed. Surgery for morbid obesity is even higher risk than other elective procedures, because in part the patient population, the patient who is morbidly obese, is at high risk for certain types of complications. There are things that make the risks go up. There are other things that make the risks go down. Some of those things are within our control. Some of those things are not within our control. Because this is elective surgery, we're obligated to do everything that we can that's within our control to make the risk go down, and we're equally obligated to avoid everything we can that would make the risk go up. Now, even with everything being done as well as humanly possible, we can't make the risk zero. So there's no way to guarantee safety for any one individual patient. I'll use a quick analogy to try to get that message across. When you leave here today, if you were hungry and you wanted to go across the street to get something to eat, you'd have to make some decisions. You might choose to go around the side of the building, directly across the street from our driveway to the driveway of the restaurant. It would be the shortest distance. It would get you there in the shortest amount of time with the least amount of effort. The downside, you'd have to go out across in the middle of the block. That might be a risk you're willing to accept. If not, you'd have to go the other direction to the corner. Wait for the light, look both ways before you stepped off the curb. You'd walk a farther distance, it would take you more time, and it would be more of an effort. With all of that, is that a guarantee that you're going to get to the other side, to the restaurant safely? Well, of course not. A car can run a red light, a bus can come around the corner and not see you, or you might just slip and fall on your way. But clearly, going to the corner would be safer than going across the street in the middle of the block. If you're the type of individual who wants to cross in the middle of the block, you understand the risks, you understand the benefits. Who am I to say no, that you can't? It's your choice. Now, if on the other hand, you were to take me and say, Dr. Kamelgard, come, let's go get something to eat, you would then be involving me. By involving me, I would have something to say about it. And guess what I'm going to say? I might say, sure, but let's go to the corner and wait for the light. Same thing with the surgery. This is elective surgery. There's no reason to rush into it. I want to be sure that I've done everything possible to get you into the best possible shape, both physically and mentally, prepare you as best that I can so that we can get you through this, hopefully, safely. What does that mean? Number one, I'm not going to operate on you if you're an active smoker. Smoking increases the risk of the surgery far beyond what would be reasonable, and it's within our control. There are other things that you're going to be asked to do, and you have to understand that depending on what the evaluations reveal, there are other things that I can't even predict that we might ask of you. The bottom line, safety is the number one issue. I'm not here to convince you that I need to be your surgeon. You need to feel you want me to be your surgeon. You need to feel that you agree with the type of philosophy that I have, that we've built into the program because we're looking out for our patient's best interest. We're looking out for safety as the number one issue. Now let's talk about another aspect. The other thing you need to understand is that the outcome of the surgery is not a guarantee. There's no way that I can possibly predict your individual weight loss. This operation is done to improve health risk. We know that if a medical condition is associated with obesity and you treat the obesity and the obesity improves, that the other health conditions should improve as well. Usually we're talking about things like high blood pressure, diabetes, certain cancer risks, depression, arthritis, so on and so forth. But there are plenty of thin people with high blood pressure. There are plenty of thin people with diabetes. And if your particular health issue is not related to your obesity, well, then it won't get better, or it might not get better. With specific regard to the weight loss, again, I'm not a psychic. I'm not a fortune teller, and I can't predict any one individual's weight loss. Weight loss isn't a guarantee. What I can do is try to explain that using a different type of analogy. If you are at home and you are going through a magazine, and as you go through the magazine you find a picture of a kitchen or bathroom, something pretty, and you decide you want to try to do a home renovation project. Well, let's say, for example, you've never done one before and you don't know where to begin. You might tear the picture out of the magazine, go to your local hardware store, show the person the picture and say, I want to do this at my home. The person looks at the picture, says, sure, no problem. You need this power saw, this power drill. Here's the hammer, the nails, the screwdriver, the screws, the level. You need this wood, you need this paint, you need this tile, you need this wallpaper, you need this wire, you need this plumbing fixtures, these plumbing fixtures, you need these lighting fixtures, basically everything that you need to do that project. They package it, send you off on your way after you pay for it. Well, you get home, then what? You still don't know where to begin. If you're wise about it, you probably won't even begin because you'd realize you might hurt yourself using the power tools if you don't know what you're doing. The chance of it looking like the picture when you're done really isn't very good. If you just prepared yourself in advance, read about the project, learned about home improvement, possibly taking a book out of the library, going to a seminar or a workshop, seeing a demonstration, having a chance to demonstrate back. If you made a mistake holding the power tool, using it the wrong way, the instructor could then correct your mistake so that before you ever left the store, you knew what you were doing. They would possibly talk to you about safety, wearing goggles, wearing a mask, doing the project in the right sequence. Then when you got home, your chances would be much improved that it would look like the picture. The chance of hurting yourself in the process would go down dramatically. Is it a guarantee? No. Is it up to the person in the store who trained you as far as how it's going to look when you're done? Of course not. Can the person in the store guarantee any kind of results for you when you get home? Of course not. Who is it up to? It's up to you as an individual. You might get home and say, you know, this is a lot more than I bargained for. I'm going to live with the house the way it is. Or you might say, I'm really excited about doing this, but I'm going to skip steps so that I can get done faster. What is it going to look like in the end? Who knows? You always have to keep in mind the picture in the magazine was built by professionals, it was photographed by professionals, and it was made to look its ideal. Now, if this is the first time you're going about a home renovation project, can you reasonably expect that you're going to get something that looks exactly like the ideal? Again, of course not. You'll probably get something that is functional. You'll probably get something that you'll be happy with, but it's not going to achieve the ideal. I consider this surgery to be a direct analogy of that example of a home renovation project. I'm going to teach you. I'm going to train you. I'm going to put you through workshops. Eventually, I'm going to test you. Hopefully, you'll eventually get your surgery. After the surgery, you go home. When you do, it's up to you. What you put into it will be what you get out of it. If you go home, raise your hands, kick back, relax, say, Dr. Kamelgard did the operation, now all I have to do is sit and wait. It's not going to happen. You need to take an active role. You need to take an aggressive involvement. This is going to be your life for the rest of your life. If you do follow the guidelines, if you do the diet and exercise, stay in follow-up, you can achieve something that you'll be happy with. This operation is not designed to get you to your ideal body weight. It's designed to get you to a healthy body weight. Okay, if you can keep that in mind, if you can understand that that's how this works, you can be happy. If your goals and expectations are unrealistic, if you think you're going to get an ideal body weight, you're going to be very disappointed. So, what I think you need to do is keep in mind the limitations of the operation, keep in mind how it's designed and what it's expected, and from that, if you have realistic goals, realistic expectations, you can be very happy and achieve a healthy weight and a healthy life. What I'd like to talk about next is the process a patient goes through in our program. Every patient goes through a very similar process. Thorough medical examination, thorough psychiatric examination. Those examinations can either be done here by our physicians or they can be done on the outside by your physicians. Our physicians are familiar with what I'm looking for, and I'm familiar with the quality of the reports I receive. If you go to an outside physician, we have instructions that need to be given to those physicians so that the letters and reports that I get back meet the standards that I expect. If the letters I get back are not complete, I will not accept them. I cannot accept a prescription pad saying cleared for surgery. I cannot accept a physical examination that all it says is within normal limits. What I'm looking for is something more thorough than that. Once we get those evaluations and I receive them and review them, then we'll determine if we're ready to proceed. Based upon those reports, we might need additional testing, we might need additional medical treatments, might need additional psychological treatments. Whatever it is that those reports reveal, those issues need to be addressed prior to proceeding. Once those reports are complete and we proceed, we go to the insurance company for pre-certification. We have to wait for the pre-certification process, and the insurance company has to give us the go-ahead. When we receive that, then we start you on the second phase, the interactive part, the workshops. We put you through a series of visits with our diet nutrition counselor. We put you through a series of visits with our physical therapists. Those need to be completed as well prior to your being given a date for surgery. Eventually, we get through all of that and we get you to the date of your operation. On the date of your operation, you arrive at the hospital, you have your surgery. That evening, you'll already be out of bed in a chair. The following morning, we'll take you by wheelchair down to the physical therapy gym, where you'll be ambulated. They'll get you up, moving around. That day, we'll start you on ice chips and sips of water. You'll also be expected that day to be up out of bed, getting around out of your room. The second day after surgery, we start you on oral medications. We start you on a modified liquid diet. And at that point, we're already getting you ready for discharge home. In order to go home from the hospital, there are some very basic requirements that a patient has to achieve. They have to have their pain under control with the oral medications. They have to be able to get up, move around freely enough that they can get to the bathroom, care for their daily needs. And they have to be able to take in enough liquid by mouth that we can shut the intravenous and not worry that they'll dehydrate. It's usually about 4 ounces per hour. By the third morning after surgery, virtually all patients have achieved those goals. Many actually achieve those goals the evening before, and if they live within about half an hour of the hospital, we'll typically let them go home. When a patient goes home from the hospital, they go home on a modified liquid diet with their oral medications and oral pain medicines. Then they come back for their first follow-up about a week later, 7 to 10 days or so from the surgery. Their diet is advanced to soft foods. And then they come back for subsequent visits at their 1-month anniversary from the surgery, 3, 6, 9, and 12-month anniversaries from the surgery. During the second year, it's 18 months, 24 months, and then after that it becomes annual. Follow-up is lifelong. There are potential problems that can arise even years later after surgery for morbid obesity, and if somebody's not following you on a regular basis, a small, otherwise treatable problem can develop into a major disaster. That's part of the reason why we tell all of our patients, if you're away on vacation, if you move, if you happen to find yourself in an unfamiliar environment, and you go to a doctor or you go to the hospital because you're not feeling well, if they've never seen a patient who's had gastric bypass, if they're not familiar with the types of issues and problems that can arise, they need to get on the phone, they need to call us. There's a lot of information we can communicate over the telephone. If we don't hear about it, we can't help. So you need to stay in touch. What I'd like to do next is talk about the surgeries that can be performed for morbid obesity. It turns out we're not talking about one surgery. We're talking about a variety of surgeries. As a matter of fact, surgeries fall into 3 main categories. There's a category of restrictive operations. There's a category of malabsorptive operations. And then the third category is a combination of the other 2. When we talk about restrictive operations, we're talking about operations that only involve the stomach. Those operations might be called stomach stapling, gastroplasty. Some of you may have heard the expression VBG, vertical banded gastroplasty. Some of the operations involve banding. Some of the operations involve placing a ring. Some of the banding operations are adjustable bands. And these operations can all be performed either with traditional open surgical technique or laparoscopic surgical technique. Whatever the case might be, they're still restrictive. All they do is create a small stomach pouch, allowing you to feel full after a small amount of food. Those operations can achieve reasonable amounts of weight loss. Unfortunately, there are some downsides. They don't achieve the same type of weight loss as the other categories, primarily because patients learn they can beat the operation. what do I mean when I say beat the operation? Patients can learn that if they drink milkshakes, eat ice cream, have high sugar content foods, sweet eaters in particular, that they overcome the restrictive part of the operation. The calories still get into their digestive system, and there's no adverse consequence. As a result, they don't lose the same amount of weight, or they'll lose weight and gain it back. Now, at the other end of the spectrum are the malabsorptive operations. Those operations are designed to create malabsorption. That basically means it doesn't limit how much food a person takes in, but it makes the food pass right through. Now, those operations are much more common in Italy and Canada, where they were developed, but they are being performed here in the United States as well. They are very effective in weight loss, but they also produce side effects. Those side effects might be diarrhea. In many cases, as many as a third of the patients can develop chronic diarrhea, sometimes requiring reversal of the operation. Patients who have that type of surgery might develop foul-smelling, greasy stool, flatulence. These patients might have accidents, might not be able to get to the bathroom quickly enough. And in addition to vitamin and mineral deficiencies, some of these patients can develop nutritional deficiencies. The middle of the ground, so to speak, the combination operation, is the operation that's most common in the United States. The most common form of that operation is called the gastric bypass. It involves an element of restriction and an element of malabsorption. Together they work and help each other out. The restrictive element creates a sense of fullness after eating a small amount of food. If you try to beat that part, as with the regular restrictive operations, the malabsorptive part will kick in. And the way it kicks in is a pretty significant kick. It'll give a patient what's called a dumping syndrome. The body gets overwhelmed with the amount of sugar. It causes a significant rise in the blood sugar, which causes a significant rise in the insulin levels, which therefore drops the blood sugar levels precipitously. Patient might feel lightheaded, dizzy, sweaty. The intestine tries to dilute the amount of sugar that's in it by pulling in fluid from the rest of the body, making a patient feel bloated, gassy, crampy, and eventually, usually, results in significant explosive diarrhea. Basically, a patient learns very quickly, can't eat that food. It's like the child who tries to steal the candy bar and the parent who slaps them on the hand, teaching them, you can't steal. So, together, the combination operation helps reinforce the good behavior and punishes the bad behavior. That's how the operation works. The operation can be performed either of two ways, with a laparoscope or traditional open surgery. What I'd like to do next is draw some pictures for you so you have a better understanding of what's involved in the two operations. I'm going to draw a few pictures. The first picture is going to be a schematic drawing. That's going to be a little on the small side, but this is going to be used as a reference diagram from which we're then going to draw the rest of what's taking place during the surgery. In this schematic diagram, I'm going to label this up here as A. This is going to represent the esophagus. Over here is the stomach, and I'm putting the label B. This part here is the first part of the small intestine, called the duodenum. I'm going to put a label C over here. And the rest is the small intestine, and I'm going to put label D and E, representing the first part of the small intestine, a length of approximately 100 centimeters, which is the equivalent to about 3 feet. On this side, I'm going to draw a schematic of an abdomen. And on this side, I'm going to draw a schematic of another abdomen. If we perform the surgery with a laparoscope, there are six incisions required. One just above the belly button, one just beneath the breastbone, two in the right upper abdomen, and two in the left upper abdomen. This incision, this incision, this incision, and this incision each measure approximately 1 inch. This incision is slightly larger, and this incision is slightly smaller. So the total is approximately 6 inches worth of incision length. On this side, if we make the operation through a traditional incision, we have a single incision whose length is approximately 6 to 8 inches long. On the inside, the operation has similarities, but it also has differences. If I draw first what happens on the inside for the traditional surgery, both surgeries involve dividing the stomach into two pieces. In the case of the traditional open surgery, the stomach is divided in a way that looks like a thumb for a pouch. This is labeled A again, representing the esophagus up here. This thicker line indicates where we've stapled and cut. There's a matching staple line on the excluded part of the stomach, and then the remainder of the stomach with the sweep of the first part of the small intestine, like so. This is B, and this is C. The intestine is cut at that point, and a piece of intestine is brought behind the stomach and behind the colon and brought into the position between the stomach pouch and the excluded stomach. This is D, and this is E. Now things have to be hooked back together. This connection is done with a stapling device. This connection is done by hand. To control for the size of the outlet through which the food has to pass, we place a mesh band around the distal part of the stomach pouch, and that controls the size of the outlet, the restrictive element. This piece of intestine is tacked to the staple lines to reinforce it, and with this configuration, food comes into the pouch, flows through the pouch into the small intestine, it's carried down, and it passes this point here where the two limbs of bowel are joined. The stomach produces its acid, which flows into the duodenum. Bile from the liver flows into the duodenum. Pancreatic enzymes flow into the duodenum, and together they join up with the food at point C, point where C and E are connected. And this is the Y of the Roux-en-Y connection. When we do the operation with the laparoscope, again, it's very similar, but there are some subtle differences. When we cut the stomach pouch, because of the technique that we use, the pouch comes out looking slightly different. It comes out looking more globular or round. Again, labeled A for the esophageal area. The excluded stomach separated from the remainder of the gastric pouch. The sweep of the first part of the small intestine. Again, labeling the stomach B, labeling this point C. Again, bringing the small intestine behind the colon, behind the stomach, up to the area of the gastric pouch. But here you see what we're doing is looping it in this configuration. So this is point D. We again bring point E to point C, and we make this connection with a stapling device. Up here, we use another stapling device that makes a hole on the back side of the stomach pouch, connecting the stomach pouch to the small intestine. In this fashion, the food comes into the pouch, drops through the hole into the small intestine, which flows down behind the colon and behind the stomach, again passing the point where C is connected to E. In the same way as here, the stomach juice, the bile, and the pancreatic enzymes flow down to point C and join the food, forming the Y of the Roux and Y connection. With these operations, there are also drains that are placed. In the case of the traditional surgery through a single incision, there's a single drain that comes out through a separate stab hole in the skin connected to a compression device. This drain is removed prior to the patients being discharged from the hospital. With the laparoscopic operation, there are two drains. One on the patient's left side, also through a separate stab hole in the skin. This is connected to what looks like a test tube. This is a small drain, and this is also taken out prior to the patients leaving the hospital. One additional drain that comes out through the hole that's already there from the incision of the surgery. This drain comes out from inside the abdomen. This is connected to a device that looks like a little hand grenade. This device goes home with the patient with the drain in place and isn't removed until the patient comes for their first follow-up visit, at which time the drain is pulled out in the office. When we talk about complications of this type of surgery, what we're really talking about is a spectrum from minor to major. Minor complications might be something as simple as more pain than you thought you were going to have, possibly being out of work longer than you thought you were going to be out of work, or maybe not losing the weight you thought you were going to lose. At the other end of the spectrum would be something major like dying. Now, there's a lot in between, but we need to keep in mind this is high-risk surgery. A complication like dying, statistically, occurs in about 0.5% of all patients who are having this operation. That's 1 out of 200. Of those patients who might die, the older a person is, the more comorbid conditions they have, the more they weigh, the higher the risk. But obviously, even someone who's morbidly obese but younger and otherwise healthier is still at very high risk. If we break the complications down into categories, we can talk about risks from anesthesia, risks from surgery in a general sense, and then risks specific to this operation in the short term and then in the long term. When we talk about risks from anesthesia, we're talking about heart attack, stroke, blood clots that can form in your legs or pelvic veins. If those were to happen and they were to break free, they could travel to your lungs, where they could cause chest pain, breathlessness, or in the worst case, sudden death. Other types of complications as a result of anesthesia include breathing difficulties, pneumonia. Pneumonia in somebody who's morbidly obese can be a very serious complication, even life-threatening. That's why we work so hard preoperatively to try to teach you to take a deep breath. We use what's called incentive spirometry training. A little machine, you suck on the tube, you make the balls go up in the air. That's to help teach you before surgery how to take a deep breath. When we talk about risks from surgery in a general sense, we're talking about the fact that anytime we cut the skin, we're breaking the body's natural defense barrier. There's a chance of infection, there's a chance of bleeding. We're going into the abdominal cavity, there's a chance of developing a hernia. Now, for these complications, the laparoscopic operation has an advantage over the traditional surgery because 6 1-inch incisions are less likely to get an infection and less likely to get a hernia compared to the larger incision of the traditional operation. When we talk about the problems that can happen on the inside, again, you can have leakage. With the laparoscopic operation, there is between a 1 and 4% chance of developing a leakage. Now, a leakage is a very serious complication that can occur with either operation. If a leakage were to occur, an infection would set in the abdominal cavity. With this operation, the leakage rate should be 1% or less. Because the chance of leakage is up to 4 times higher with the laparoscopic operation, this additional drain, which is placed in the area of the gastrojejunal anastomosis, is used to help control any leakage. If leakage were to occur, 3 out of the 4 cases, the drain would be enough to control it. And only in the remaining 1 would there be a situation where the patient might need additional surgery. This is equivalent to the 1% that would occur if we did the surgery open and there were no drain at all. Additional surgery might entail going to the intensive care unit, being on a ventilator. It can result in an abnormal communication from the intestinal tract to the skin, something we refer to as a fistula. With the laparoscopic operation, we use that extra drain to help control a leakage if a leakage were to happen. The rate of leakage is so much lower with the traditional operation that we don't even put the drain. If a leakage, again, were to happen and the infection were severe enough, it could overwhelm your body's defenses. And if that were to happen, it could lead to a syndrome called sepsis, which could be lethal. Other types of complications, again, this operation involves cutting the stomach, cutting the intestine, moving things around, making new connections. Any place we cut and divide, any place we make new connections, there's a chance of leakage, but there's also a chance of developing blockages. Blockages can happen because of kinks or twists. Blockages can happen after the surgery because adhesions might form and the bowel can twist or get pinched off. Some of these blockages can happen even years later, just as they can happen after any abdominal surgery. If a blockage were to happen, it doesn't have to be a life-threatening complication, but it could become one, especially if it's not identified and not addressed. Sometimes it requires additional surgery. Now, one type of blockage that is more common with a laparoscopic operation than the traditional operation is called an internal hernia. An internal hernia is where the bowel twists through a space that it shouldn't normally be able to. And some people think that's because with the laparoscopic operation, there are fewer adhesions that form. Blockages due to adhesions are more common with the traditional surgery, again, because more adhesions are formed. With the laparoscopic operation, we're making a connection between the stomach pouch and the small intestine using a stapling device. The stapling device cuts a hole of a very specific size. Unfortunately, as people heal, that hole can get tight and form what we call a stricture. If that happens, food can't pass through, and a patient would vomit. When that happens, we sometimes have to put a balloon down through the mouth, into and through the anastomosis, and blow it up to literally stretch the hole open. That happens in about 5% of the cases. With the traditional open surgery, we don't have that particular complication because we make a nice big anastomosis and we rely on the mesh band to keep the restriction. The mesh band doesn't stretch, it doesn't shrink, and therefore we don't have that same type of complication. Let's look at some of the other complications that happen more along the timeline farther out from the surgery. If a person doesn't take their vitamin and mineral supplements, they can get calcium deficiency, iron deficiency, vitamin deficiency, especially the B vitamins, B12. If a person doesn't drink enough, they can get dehydrated. Dehydration can result in constipation, which can be very severe. Dehydration can result in kidney stone formation and even kidney failure. Other types of complications that can occur: some patients can develop gout attacks. Other patients can develop liver failure. Other patients can develop psychiatric problems, eating disorders, body image issues, depression, especially if their goals and expectations haven't been met. Sometimes the depression can be so severe that people have been known to commit suicide. The bottom line, it's important to recognize this is high-risk surgery. It's important to know what the risks are. If a problem starts to show itself, it needs to be addressed. The earlier it's recognized, the earlier an intervention can be initiated, and the better the chance of a successful outcome. So you always have to keep these complications in mind. The bottom line, however, is if you look at all the complications, all the risks and the benefits, which are improved health, and you compare those to the risks of not having the surgery, we know that if you put them on a scale side by side, surgery wins out. We're not talking about one thing being good and one thing being bad. We're talking about two things, neither of which is good. We just have to select that which is less bad, the lesser of the two evils. For the majority of patients, if they're candidates for surgery and the remainder of their health issues are stable, surgery is that lesser of the two evils. After you finish watching this videotape, you're going to come in and meet with me one-on-one. I'm going to ask you 3 questions now that I would like you to think about so that we can discuss them, or rather we can discuss the answers when we meet person to person. The first question has to do with your goal and expectation with regard to your weight loss. I'm not talking about improvement in your health, because again, there's no way to know exactly. There's also no way to know how much weight you're going to lose, but I'm sure you have some expectation. So that is the question. What is your expectation with regard specifically to weight loss? How many pounds do you expect this surgery is going to help you lose? I'm not asking for your hope. I hope to hit the lottery one day maybe and be able to retire early, but I don't expect it. What is your expectation from the surgery? The second question is, how long is it going to take you to achieve that weight loss? And then the third question, how little weight, what is the least amount of weight that you would need to lose to feel like taking this drastic step of having surgery was worthwhile? So again, the three questions: what is your expectation? How much weight do you expect you're going to lose? Number two, how long is that going to take? And then number three, what is the least amount of weight that you need to lose to feel like this was worthwhile? Now, as I keep saying, I can't predict your weight loss, but what I can do is talk to you about what would be typical. We know that if you take all the patients who have this kind of surgery all across the country and follow their weight loss after the surgery, they lose their weight rapidly at the beginning, it slows down, and then bottoms out at about a year to a year and a half after their operation. Then it rebounds a little bit, and then their body will stabilize. That rebound can vary from person to person. There are lots of different reasons why that rebound occurs. One is the body just becomes more efficient at getting the calories out of the food that you're giving it. So even though you're reducing the amount of food, and even though you're burning the same amount of calories, the body is getting more calories out of that lesser amount of food, and it's as if you're eating more. By increasing its efficiency, it causes you to take in more calories, and therefore, you'll gain some weight back. If your goals and expectations weren't realistic, if, as an example, a person is 100 pounds over their ideal body weight, and they truly expect to lose 100 pounds, when they stop losing weight, let's just say 65, 70, 75 pounds, they're going to still be away from what their expectation was by a significant amount. At that point, they're going to feel like a failure. They're going to feel like the operation didn't work for them. If they're a failure and the operation didn't work, they're not going to keep up with the diet or the exercise. If you don't keep up with the diet and the exercise, you'll gain back more weight. On the other hand, if somebody's goal and expectation was to lose 65, 70, 75 pounds, and they lost that amount of weight, well, all of a sudden they feel like a success. The weight loss happened the way it was supposed to happen. That encourages them to stick with the diet, stick with the exercise, to stay with the program. Well, if you stay with the program, you usually will achieve better results that will last longer. So what's average? What's typical? The weight loss comes off over the first year to a year and a half, stabilizes after another year to a year and a half, and the point at which it stabilizes, the person has typically lost 2/3 of the extra weight that they started with. So that person who starts out about 100 pounds overweight will end up losing about 67 pounds. Again, that's an average. There are patients who do better, patients who do worse. If you keep in mind trying to be average, you can be happy with your results. If you're trying to shoot to be in that top percentages of all the people that have ever had the surgery, if you're setting yourself up for failure, you're going to be miserable. And if you're miserable, you're not likely going to stick with the program. What I'd like to do now is talk to you about one last thing. Rubber bands. If I take this rubber band and stretch it and let go, it snaps right back. If I take it and stretch it and leave it stretched for a long time, a year or two, when I let go, it's not going to snap back. It loses its elasticity. Skin has the same property. When you're morbidly obese, your skin is stretched out of shape. When you lose weight, the filler's gone, but the skin is still stretched out of shape. It becomes flabby, sags, hangs. There's no exercise in the world to help skin regain its elasticity. None. There's only one way to get rid of that extra skin, and unfortunately, that's more surgery, to cut it off. That's usually considered cosmetic surgery. It's not typically covered by insurance. It can be quite expensive. And if body image becomes a significant issue, and you are unhappy with the way you look afterwards, that can be a problem. What I recommend to all prospective patients, regardless of who's going to be your surgeon, where you're going to get the surgery done, if you're going to take the drastic measure of having surgery to help you reduce your weight, go to your local bank, open a gift savings account, like a Christmas club. The money you save in food bills every week, put it aside. If you save at least $50 a week, and I'm sure your food bill savings are going to be more, but if you put away $50 a week, every week, over the course of the 3 years, even without interest, that'll be nearly $8,000. $8,000 will come in very handy in getting cosmetic surgery. It may cover it, it may not cover it, but it'll be a start. If you don't plan for it, it becomes very difficult. If you plan for it and you decide not to use it, use the money for something else. Take a trip, buy some extra clothes, new car, whatever. Plan ahead. Very important. Well, I'm going to stop here because I know I've covered a lot of material. There are a lot of details, a lot of information. In a few moments, you'll come into my office and we'll meet one-on-one. Again, remember, I'm going to ask you 3 questions, or rather the answer to the 3 questions I've already asked. And I want you to understand, I'm not going to run after you as a patient. The decisions to make are not going to be mine. They're going to be yours. You need to decide this is what you want to do, and you need to let me know. If you don't decide and you don't let me know, that's okay. I'm not going to call you. I'm not going to chase after you. This is a low-key program. We don't chase after patients. You need to take the responsibility and understand you need to want me to be your surgeon. You need to want to participate. And when you make that decision, we'll be there to help you. Again, thank you for your time. Thank you for listening. And in a few moments, we'll meet one-on-one.